Welcome back to the equine anatomy lectures. We're continuing our last lectures on the equine limbs, and we started with the forelimb. We mentioned how important studying the equine limbs is. Basically, we have a number of cases like sole abscesses, navicular disease, laminitis, OCDs, you name it. So there's a lot of clinical cases there. And we also mentioned that the forelimb has 6 articulations, 6 joints, shoulder joint, elbow joint, carpal joints, fetlock joint, pastern joint, and coffin joint. We also mentioned that we have a number of muscles uh, all the way from the scapula to the distal end of the radius. And on the scapula, on the lateral side, we have the supraspinatus and infraspinatus. And on the medial side, we have the subscapularis muscle. Now, on the humerus, we have the biceps brachialis on the lateral aspect, and also we can see it on the medial aspect as well, and also the triceps brachialis with all its heads, the the long head, the lateral head, and the medial humerus head. Now on the lateral aspect of the humerus, we have the extensor carpi radialis and the extensor carpi obliquus. The common digital extensor. As you can see, all of these are extensors on the lateral side. We have the lateral digital extensor also. Then we have the ulnaris lateralis and the ulnar head of the deep digital flexor tendon. Now, on the medial aspect, I mentioned earlier that we don't have much muscles. Well, we have the flexors. Well, we have the biceps and the laceratus fibrosus, which we said it's going to be important for the passive stay apparatus, and then we have the flexor carpi radialis and the superficial digital flexor and the deep digital flexor as well. On the medial aspect, I mentioned earlier that we do not have muscles. This is basically a picture showing the medial aspect of the radius, which is number 9 here, and you can see that there is no muscles on this surface. This becomes an important concept I mentioned earlier, because we're gonna utilize this area, for example, to treat a common congenital deformity in the newborn foals. We call those angular limb deformities. This is a picture of one of the cases of an angular limb deformities. It's called carpal valgus. Valgus is the toe is pointing toward the outside, and that shows that the one side is growing faster than the other side. So this bone is growing faster. That's why it's going outward. Okay, that's why it's going outward. So that means that the medial aspect is growing pretty fast compared to the lateral aspect. And so another case is carpal varus, which is basically toward the inside. The toe is basically pointing toward the inside, which means that the lateral side is growing faster than the medial side. So how would we treat certain cases? Either by promoting the growth of the side that's growing slower, or by inhibiting the growth of the side that's going faster. So we have these two hypotheses, if you will, and so if the medial side was growing slower than the lateral side, the medial side of the radius is growing slower than the lateral side of the radius, we perform a procedure that's called periosteal stripping. So, as I showed you earlier, on the medial side of the radius, there's no muscles. So what we do is simply we incise the periosteum in an inverted T-shaped incision, and then we peel the periosteum pretty gently. We peel the periosteum and then we close the skin normally. With this, what we do is we promote the growth of the medial side of the bone, which is growing slower, growing slower. Now, if the side is growing faster than the other side, what we can do is we can inhibit the side that's growing faster, and this by doing the following procedure. It's called transphysial bridging. Basically, what you do is you make a bridge between the two sides of the physes, which is this right here. And so what you do is you put two screws and you tighten the screws with a surgical wire. And with that, you have to tighten this uh, 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 based on the development of the case, of course. This will cause retardation of bone growth. So the side that's growing faster will start to grow slower. So you basically inhibit the growth of the bone on that side. So this is in the fetlock as well. You can put one screw here, and also in the carpus you can put two screws and bridge them with a surgical wire. Now the key here is basically to inhibit the side of the bone that is going faster. Inhibit the side of the growth of the bone on the side that's growing faster, versus the periosteal stripping, which basically promotes the growth of the side that's growing slower. So depending on what you want as a surgeon, you apply the technique that you like. Sometimes, of course, you have certain complications, especially for the transphysial bridging, and that is a breaking of the wire. This is a case of breaking of the wire. So you basically will put the horse down again and re-put a new wire here, which can happen sometimes. So these are the two procedures that can be done, and utilizing the medial aspect, if you like, which has no muscles. It's always better to cut as less tissue as possible during surgery. If you can get away with cutting less tissue, that's perfect. If not, then you have to cut what you need to fix the problem. So you have the two the two procedures that can be done on the medial side. If you see that the medial side is growing faster, then you need to inhibit that side by doing transphysial bridging. If you feel or if you see that medial side is growing slower, then you have to promote the growth of that side and you do periosteal stripping, depending on what the case is. Now, let's go back to the muscles again that we studied earlier. I told you before that you will see a number of muscles, and on the lateral side, and on the medial side you will not have muscles. You only have caudally, and you have cranially to the radius and laterally. But medially there's nothing, only the periosteum. Now, the muscles that we've talked about are the extensor carpi radialis and the extensor carpi obliquus, the common digital extensor, and the lateral digital extensor, and the ulnaris lateralis, and then the ulnar head of the deep digital flexor. On the on the dorsal aspect, and on the dorsal aspect, you have the extensor carpi radialis here, and then you have on the ventral aspect the flexor carpi radialis and the superficial digital flexor, the flexor carpi ulnaris, the humeral head, and the flexor carpi ulnaris, the ulnar head. Of course, you have the deep digital flexor also deeper to that. So basically, on the lateral aspect, you have mostly extensors. On the dorsal aspect or the ventral aspect, you have mostly flexors. I utilize this to show you basically the function for each of these muscles. Let's look at what does these muscles do, and then what are the nerve supply for these muscles. Here you have the triceps, extends the elbow, the ulnaris lateralis extends the elbow, extensor carpi radialis and common digital extensor extends the carpus. See, all of these are extensors. So you start with the elbow and then the carpus and the lateral digital extensor, and which extends the carpus and the fetlock, and the extensor carpi obliquus, which extends the carpus as well. So all of the extensors extend starting from the elbow all the way to the carpus. Pretty simple. Extensors extends the elbow and the carpus. Now, the flexors, on the other hand, they flex the elbow and flex the digit. Flex the elbow and flexes the digit. The biceps flexes the elbow. The flexor carpi radialis flexes the elbow and extends the carpus. The superficial digital flexor flexes the carpus and the digit. The deep digital flexor flexes the carpus and the digit. So, to simplify things, extensors extend elbow and carpus. Flexors flexes elbow and carpus. Two joints. Now, I want you to focus on the extensor carpi radialis and common digital extensor from the extensors, and the superficial digital flexor and the deep digital flexor on the flexor side. So this is the dorsal aspect of the radius. This is the caudal aspect of the radius. Dorsolateral, I should say here. The superficial and the deep digital flexors are on the ventral aspect. The extensors on the dorsolateral aspect. Excellent. So, first we're going to talk about what nerves supply these cases. We have the musculocutaneous nerve supplying the biceps, the auxiliary flexors of the shoulder, auxiliary flexors of the shoulder, radial extensors radial, extensor of the elbow and carpus and digit, and median and ulnar flexors of the carpus. I will repeat. All of the nerves that supply the forelimb comes from the brachial plexus. Now, I want to focus on 4 nerves. I don't want to focus on all of these nerves. I only want 4 nerves. The musculocutaneous, which supplies the biceps. The biceps runs here on the humerus. The auxiliary flexors of the shoulder. Auxiliary flexors of the shoulder. Radial extensors of elbow and carpus. Radial extensors of elbow. This is the elbow joint and the carpus. Extensors. Extensors. Extensor carpi radialis. Common digital extensor, etc. Extensor of the elbow and the carpus. Medial and ulnar. Median and ulnar flexors of the carpus and digit. And I told you the muscles that we need to focus on here. Superficial and deep digital flexors. This is medial and ulnar nerves. The radial is the extensor. The radial is the extensor. Extensor carpi radialis, common digital extensor. All of them are extensors, and they are on the lateral and dorsal aspect of the radius. Dorsolaterally, they are located. Dorsolateral. Biceps is musculocutaneous, and auxiliary is flexors of the shoulders. Now, if any of these nerves is injured, what's going to happen? Let's look at clinical cases that will show us what we will see in injuries of each of these nerves. I mentioned earlier that the innervation of the forelimb comes from the brachial plexus. So if the brachial plexus is injured, trauma basically, falling, kick, anything like this, you will have atrophy of all of the muscles of the forelimb. You can see atrophy of the flexors, extensors. Flexors are here, caudally. Extensors are here, dorsally and laterally. Lateral aspect of the humerus, lateral aspect of the scapula. All of the muscles are pretty atrophied. This is a chronic case of brachial plexus injury. Now, let's take one nerve at a time. I mentioned on the lateral aspect of the scapula, you have the supraspinatus muscle and the infraspinatus muscles. Let's see what happened to the nerve that supplies them, that comes between them. And it's called the supraspinatus nerve. You will see that with this injury, you will have atrophy of these muscles. This is the supraspinatus. This is the infraspinatus muscle. This is the spine of the scapula right here. And you will see atrophy in these muscles. This case is called Sweeney. And the reason for this is because the suprascapular nerve is pretty superficial. It's under the skin, directly under the skin. And so when horses traumatize their shoulder area, they have a tendency to traumatize this nerve as well. And this nerve supplies these two muscles. So when the nerve is injured, the muscles are paralyzed or atrophied in the chronic case. So when the nerve is injured, the muscles are paralyzed. They do not move. They do not function. And when they are paralyzed for a long period of time, they become atrophied. Very important. So this is the second nerve. First we talked about the brachial plexus as a whole, and then the supraspinous nerve. Then let's take a look at the next one. And you can see two injuries here. Two injuries. If you remember, the muscles of the neck, the brachiocephalicus, which has two parts here, cleidiomastoidus and cleidiobrachialis, right here. It's atrophied. It's atrophied. Now, the other muscle is here, and it's also atrophied. It's the deltoides muscle. So the deltoides muscle is atrophied, as you can see here, and the cleidiobrachialis muscle is also atrophied. You can see that pretty clearly as shown by the white arrow here. This is a classic injury of axillary nerve paralysis. Axillary nerve paralysis. Again, trauma, falling, kicking, etc. will injure the nerve, and you will have atrophy. Again, first paralysis of the muscles supplied by the nerve, the axillary nerve. When you have paralysis of the muscle for a longer period of time, then muscle atrophy will take place. Very important. So we had three injuries now: brachial plexus, supraspinous nerve paralysis, Sweeney, and then axillary nerve paralysis or axillary nerve injury, which causes paralysis of the muscles. This is a radial nerve paralysis. Radial nerve paralysis. Look at the injury here and look at the muscle atrophy that's happening here. The limb, we call that a touch toe. Lameness, non-weight bearing lameness, and also you have atrophy of the muscles of the shoulder and the brachium, and antebrachium, which is basically the radius and the ulna, as well as the shoulder. All of them are supplied by the radial nerve. All of them are supplied by the radial extensors, basically, as we mentioned earlier. The extensors of the elbow, carpus, and digit. The extensor of the elbow, carpus, and digit. All of them are atrophied. You can see the muscle atrophy right here. This is a radial nerve paralysis. The sensory innervation of the forelimb comes from also the radial nerve, which supplies the dorsal aspect and the lateral aspect of the shoulder and also of the elbow, and the ulnar nerve, which supplies most of the lateral, dorsal, and ventral aspects of the elbow, carpus, all the way to the fetlock joint. The median basically goes to the digit and to the dorsal to the ventral aspect of the metacarpus. Digit and metacarpus. And we will talk about that when we talk about the nerve blocks. But this is the sensory innervation of the forelimb. Now, we need to switch gears, if you will, and talk about another important structure in the forelimb. This structure, or these structures, are called bursas. Bursas. We have olecranon bursa. We have a bicipital bursa, where the tendon of the biceps is olecranon at the level of the olecranon process of the ulna, and we have the biceps tendon on the humerus. Also, there is a bursa underneath it. The bursas, as you remember, are spaces that are filled with synovial fluid to reduce the friction, because these are continuously moving areas. And so we need this synovial fluid, this 10W30, to lubricate the area to reduce friction. But sometimes this synovial fluid, when the horse gets older or when there's an injury of some sort, these cases gets pretty bad, and the bursas gets infected. Sometimes they become calcified, become like bone, and so we have names for these cases. So, for example, the bicipital bursa. The bicipital bursa is where the tendon of the biceps is, and here the area becomes enlarged, swollen, and full of pus, and it's hot, so it requires draining, and we'll see how you can drain these cases, and also how can you see what type of fluid, explore what type of fluid is in this bursa. Here, the way you're going to insert your needle is between the biceps and the humerus, right here, slightly above the deltoid tuberosity. You will feel the deltoid tuberosity, and once you feel that, above that, a little bit above it, you will put your needle to insert, to inject the bursa, or to aspirate fluids to see what's going on there, if you have that case. So that's basically how you do the bicipital bursa, and the disease is called bicipital bursitis. Now, this is I mentioned the olecranon bursa or bursitis, and the case sometimes becomes pretty chronic, so the pus gets dry and becomes like bone, pretty hard on the olecranon process. This case is called capped elbow or shoe boil, capped elbow or shoe boil, and to again, that's in the very chronic cases. In the Acute cases, you'll have pus in it and you have to drain it, just like here. You have to drain the olecranon bursa, and you can see the pus coming out. And sometimes you have a shoe to put to prevent when the animal moves or sits or lay down, to prevent the continuous irritation of the olecranon area. So this shoes basically prevent that continuous irritation. So with that we basically covered the innervation of the forelimb, and a couple of clinical cases that are associated with either injury of the nerves or injury of the bursas. Next time we will talk about the passive stay apparatus in this area. Again, the passive stay apparatus is the mechanism by which you or the horse utilizes less tensions on the joints and the muscles and the tendons, so that the weight is distributed in a very nice way, so the joint will not carry a lot of the weight of the horse, because the horse is always standing or standing for a long period of time. So that's why you need this passive stay apparatus to help in this process. So we'll talk about that next time, and we'll continue on the clinical significances of the different structures of the forelimb.